This presentation is about drugs affecting the cardiovascular and renal systems. This will be presented in two parts. We'll start with the ACEs and ARBs, and there's also another not as widely used category of direct renin inhibitors, which is Tecturna. So mostly we'll be talking about ACEs and ARBs. So all of these drugs have multiple uses in the cardiovascular system. Of course, they act on the renin-angiotensin-aldosterone system to lower blood pressure. And so the ACEs work by inhibiting angiotensin-converting enzymes. So they do not allow angiotensin 1 to be converted to angiotensin 2. And so that decreases production of both angiotensin 2 and aldosterone. So just for a review of what angiotensin 2 does, it increases vasomotor tone by direct stimulation of the vascular smooth muscle contraction and through inhibition of nitric oxide in the endothelium and causes prostaglandin release. That raises the blood pressure and decreases blood flow through the arteries, including the coronary arteries. It also increases intravascular volume because it stimulates sodium and water retention along with aldosterone, and this alters the glomerular hemodynamics in the kidneys. It also is produced in response to tissue injury, so that promotes the atherosclerotic process, and it also causes remodeling in the heart by causing hypertrophy and fibrosis of the myocardial tissue. So there's strong evidence for cardiovascular and cerebrovascular risk reduction, heart failure, and the slowing of renal disease with the ACEs. It can improve oxygenation to the heart muscle, so that decreases remodeling, and so there's particularly useful after MI or in patients with heart failure. And because of its renal protective activity, it can reduce the effects of diabetes on the kidneys. This slide shows what angiotensin-converting enzyme does. It increases the conversion of angiotensin 1 to angiotensin 2. And angiotensin 2 is what we want to prevent because that's a potent vasoconstrictor that causes an increase in blood pressure. But the angiotensin-converting enzyme also acts on bradykinin to facilitate its breakdown. And bradykinin is a good vasodilator and can decrease blood pressure. So if we inhibit the angiotensin-converting enzyme, we increase that vasodilation and therefore thereby decreasing blood pressure. Bradykinin also plays a role in inflammation, and it's the bradykinin, the high levels of bradykinin that we get from ACE inhibitor use that are thought to be a factor in the cough that's produced as a side effect. So how do they provide renal protection and prevent diabetic nephropathy? They can cause a diminished proteinuria, which will delay glomerular hypertrophy, and so they can slow the rate of decline of the GFR. So there's decreased arterial resistance in the kidney along with reduction in the capillary pressure in the glomerulus, and that's how it reduces the proteinuria and decreases the GFR. So these are the common ACE inhibitors that we use and their doses and maximum doses and initial doses. And most of these can be combined with hydrochlorothiazide, which actually can offset the elevation in potassium you can get with ACE inhibitors. So most ACE inhibitors are excreted in the kidney and metabolized by the liver. Captopril is considered the prototype for the class, which is rapidly absorbed and on an empty stomach has a high bioavailability at around 70%. Adverse drug reactions with ACE inhibitors, the cough, and that's that bradykinin-mediated effect. Of course, hypotension, I already mentioned hyperkalemia. Angioedema is not that uncommon, so that's something to watch out for. So in monitoring, we do need to look at renal function. While it does, ACE inhibitors do want to be used in patients that are at risk for nephropathy, we do have to watch the use of ACE inhibitors when the creatinine is more than 2.5. Cough actually can occur in about 50% of patients, so it's not an uncommon side effect. And when I start them, I usually do tell patients that they may develop the cough, but sometimes it may take several weeks or months for that to be developed. And then often at that point, people aren't really thinking about that it's their ACE inhibitors. It's still a good first choice for me for hypertension just because they work well and can be attained fairly inexpensively. Angiotensin II receptor blockers are what we often go to in patients that can't tolerate ACE inhibitors, usually from the cough. And I should mention that cough is more of a annoyance than anything else. It's not something that signals, some serious side effect occurring. So patients can put up with it and stay on their ACE inhibitors, but many will not want to do that. So angiotensin II receptor blockers prevent binding of angiotensin II to receptors in the kidney, the brain, the heart, and the arterial walls. They inhibit the RAS system so they can decrease peripheral resistance. And they can be used in kidney disease until late stages and also in heart failure, but they're not renal protective like ACE inhibitors. They also have they're not considered as renal protective, at least, compared to ACE inhibitors. And there's no activity related to bradykinin, so they don't get that bradykinin-mediated cough. And as I mentioned, patients will often be switched from an ACE inhibitor to an ARB. There had been for many years generics available on ACE inhibitors and not so many for ARBs, but we do have generics now available. So we can use them more readily in the primary care setting at least. They also can be combined with hydrochlorothiazide, and thiazide diuretics work well with those classes. And as I mentioned, it offsets the potassium loss that you get with ACE inhibitors, but that's not a common side effect with ARBs. Losartan is the prototype for ACE inhibitors. ARBs. But it's not very potent, and you can see that the first pass metabolism results in only 33% bioavailability. This is one of the major ones that is used because of its generic availability, but it's not very potent, and frequently doses need to be increased to get to maximum doses. These are the common ARBs and their initial and maximum doses. Reactions to ARBs are similar to ACE inhibitors, that is, except they, as I mentioned, typically do not cause a problem with the cough since they lack that bradykinin effect. And as with the ACEs, we do need to watch for orthostasis and monitor renal function and hepatic function, which is usually done on patients that require these drugs on at least an annual basis. And we need to let people know that hypotension is the most common side effect, and they need to be careful of that. So for patients on ARBs, no change in dosage is required based on renal impairment. An initial ARB doses may be lower for patients with impaired hepatic function. ACEs and ARBs work well for hypertension. They reduce blood pressure by decreasing sodium and water retention, decreasing vasoconstriction because of the direct angiotensin effect, and increased vasodilation due to the bradykinin effect. They are not as protective, ACE inhibitors at least, are not as protective in renal patients without proteinuria. So for heart failure, they're the only drugs that can actually address all the pathologic mechanisms of heart failure. They can reduce cardiac remodeling, and they're very effective in treating the underlying cause of heart failure, which may be hypertension. So we use these in all patients with heart failure unless there's an absolute contraindication. And we do like to start patients on these drugs before there are overt symptoms of heart failure, because they can actually prevent that remodeling that are the early stages of heart failure, even before patients are decompensating. So for patients with coronary artery disease, there are a variety of mechanisms that can help, especially in post-MI patients. They can reduce angiotensin II after myocardial injury occurs in a heart attack. They can prevent ventricular remodeling in those myocytes that are not part of the injury, or the non-infarcted myocytes. They can cause an alteration in the ventricular mass, so there's less hypertrophy, and they have a positive hemodynamic effect on the blood pressure and the fluid and electrolyte balance. So all patients that are symptomatic with chronic stable angina, we definitely want to use ACE inhibitors to prevent MI or death and to reduce those symptoms. They're also recommended to limit coronary artery disease in patients who have diabetes and left ventricular dysfunction. So the ACC and AHA recommend that ACE inhibitors be considered in patients even without left ventricular dysfunction. So ACEs and ARBs, the patient profile is generally a young Caucasian patient, but they're not as effective for African American patients. And African Americans and Asians have actually a 3 to 4 times greater increase in developing angioedema. They also have a higher incidence of the cough. And I will just mention Tecturna, that also works on the RAS system. So it can be used for hypertension. Does not have the same renal protection that the ACE inhibitors have, but it may have less issues with hyperkalemia as well as the cough. Doesn't have the same indication for MI though, and it's, as I said, it's not renal protective. So we now have a new drug class, angiotensin receptor neprilysin inhibitors, or ARNIs. We really only have one available, Entresto, which has really been shown to be a breakthrough drug, decreasing morbidity and mortality from chronic heart failure, indicated for patients with an ejection fraction of less than 40%. And this drug is a combination of sacubitril and valsartan. And there are 3 escalating doses. And the effects can be dose dependent. So it's taken in place of an ACE or an ARB, and it cannot be given with beta blockers such as carvedilol. Okay. So Entresto works on the natriuretic peptide system. And if you recall, that's comprised of 3 peptides: the atrial, or ANP, which is secreted in the atria, the BNP, or brain NP, which is secreted in the ventricles, and the C-type, or the C-type natriuretic peptide, which is secreted in the endothelial and renal cells, and these regulate blood pressure and fluid homeostasis. So neprilysin is actually a membrane-bound enzyme that hydrolyzes ANP and also less so BNP, and it also degrades other endogenous vasoactive peptides. And so inhibition of this increases the levels of natriuretic peptide, causing vasodilation and a reduction in extracellular fluid volume. Entresto also blocks angiotensin 1 receptors. So it counteracts the detrimental effects of the RAS and sympathetic nervous systems. It does require a 36-hour washout if a patient's on an ACE, an ARB, or a beta blocker. And this drug is probably akin to Coreg when that first came out, carvedilol, where it really dramatically improved treatment of symptoms of chronic heart failure. So Entresto is the next class of really looking at other ways to treat heart failure that are much more effective. Next, we move on to calcium channel blockers. As you may remember from pathophysiology, calcium is a vital component in the excitation contraction process that occurs in muscles, in the electrical excitation process, and in facilitating relaxation of myocardial muscle. So calcium enters the cells via 3 types of voltage-dependent calcium channels. There's the L type, the N type, and the T type. And the L type, or long-lasting channels, are predominant in cardiac and smooth muscle. So they're the ones blocked by most of the calcium channel blockers. And the calcium channel blockers then act as vasodilators, which cause smooth muscle relaxation because they lower that influx of calcium into the smooth muscles. There are 2 major classes of calcium channel blockers, the type 1, which are non-dihydropyridines, and they affect the conduction through the atrioventricular node. So they're good for SVT, diltiazem, and verapamil are 2 commonly used. And then the type 2 are the dihydropyridines that do not affect conduction through the AV node, nifedipine and amlodipine. And these are ones we might more commonly use for hypertension as opposed to as antiarrhythmics. Calcium channel blockers, as far as pharmacokinetics and adverse reactions, the additive hypotensive effects are major concerns with all the calcium channel blockers, especially when they're given concurrently with other antihypertensives, which they often are, or with nitrates, quinidine, or alcohol. The antihypertensive effects may actually be decreased with concurrent use of NSAIDs. So if you have a patient that's on NSAIDs chronically, which actually nobody really should be, given all the side effects that they can have, you do have to watch for a decrease in their activity. So you may have to increase doses of the calcium channel blocker in order to get the effect on the blood pressure. The more common adverse reactions of calcium channel blockers are extensions of their action. So the reduction in blood pressure that they cause that's secondary to vasodilation may result in dizziness, headache, hypotension, and syncope. And these can lead to heart failure with congestion, shortness of breath, cough, palpitations. It is a potential class effect with calcium channel blockers, but heart failure is worse with verapamil, diltiazem, and nifedipine. So the indications for calcium channel blockers, they act on both sides of the supply and demand equation. They can actually, they cause peripheral vasodilation and have a negative inotropic effect that reduces oxygen demand, but they also cause dilation of coronary arteries that increases the oxygen supply. So they're indicated in chronic angina, hypertension, SVT, and AFib. And there are also some unlabeled indications like migraine prophylaxis, verapamil's been used for that, Raynaud's, nifedipine can be used for that, and esophageal spasm, diltiazem. Next, we turn to the cardiac glycosides, which are not used very often, but do have some role in cardiovascular health. So they're highly selective inhibitors of the ATPase system. Inhibition of this pump results in sodium and calcium buildup inside the cell, and that leads to increased contractility of the heart muscle. They're among the oldest known drugs, and had been medically recognized in the treatment of heart failure since actually 1785. There are three main glycosides available, with digoxin being by far the most commonly prescribed because it's convenient and its pharmacokinetics, its alternative routes of administration, and the techniques for monitoring its serum levels. Serum levels greater than 1 milligram per milliliter can cause increased mortality if we're talking about digoxin. So we initiate therapy at the lowest dose. And we have most of our benefits in patients that have severe heart failure who are on all other drugs and are not responding to just the ACEs and beta blockers. So digoxin specifically is well absorbed orally. It's not extensively metabolized. It's excreted unchanged by the kidneys, and it has a half-life of 36 to 48 hours. So it can achieve a steady state in 4 half-lives, which is actually 1 week. So that we need to keep in mind when we're treating patients. We're not going to have a very quick effect. Drug reactions with digoxin, we all know, remember from nursing school, the visual disturbances, the yellow vision or green halos that patients may report, their central nervous system reactions, cardiac reactions. We want to avoid using them in patients that have normal left ventricular systolic function. So toxicity with digoxin, it's commonly caused by excessive administration of digoxin, or if there's too much diuresis that results in hypokalemia, puts them at higher risk. If they also have renal insufficiency, or if they're given drugs that interfere with the excretion of digoxin. And diagnosis of toxicity is based on both clinical and laboratory data. So serum levels alone are not sufficient to diagnose toxicity. Patient tolerance plus their cardiac output and vital sign outcomes are important considerations in determining when we actually have to, give patients more than or less, whatever the therapeutic range is. It's going to be different for different patients. So toxicity is an important differential diagnosis of arrhythmias in neurological and GI symptoms. As I said, diagnosis of toxicity is based on both clinical and laboratory data, and we need to be correct in our timing or we're going to miss toxicity. Draw it 6 hours after the last dose. Take it the same time each day. We have to tell patients to be mindful of what their heart rates are. Take it every day at the same time. Check their heart rates. Monitor for signs of toxicity, so they need to know what those are. Indications for digoxin include atrial fib, SVT, and heart failure. With atrial fib and SVT, it does have a negative chronotropic effect, so it slows the heart rate and thus enables conversion to sinus rhythm. For heart failure patients, it does have a positive inotropic effect, but we use it in severe systolic dysfunction with EFs of less than 40%, and only in patients that are already on ACE inhibitors, ARBs, and diuretics. Our next group of drugs is antiarrhythmics. And there are several slides here which I'm not going to go over now that review physiology of dysrhythmia. These slides talk about what normally happens in the cardiac cycle. You can review this. I will stop here to talk a little bit about reentry, which is the cause of some of the arrhythmias. So normally impulses go from the AV node and can go down both pathways in the same direction. But if a block is encountered by the action potential in one of the pathways, then it can only go down the other pathway. The impulse can then return to the initial point of bifurcation and re-excite the myocardium. So you get this short-circuiting conducting tissue that can cause premature contractions. And if it's repetitive, it can cause something as serious as VTAC. So the goals of therapy with patients that have arrhythmias are to reduce the ectopic activity or alter the abnormal conduction pattern. And the major mechanisms are listed here: sodium channel blockade, calcium channel blockade. There's actually some potential potassium channel blockade as well. Blockade of the sympathetic nervous system, effects on the heart, and prolongation of the refractory period. So the antiarrhythmic agents are listed in 4 categories. The class 1 drugs are membrane stabilizing agents, so they're sodium channel blockers. And then you have 3 categories of the class 1s, which are listed here. Class 2s are beta blockers. Class 3s are agents which prolong the duration of the action potential. They can be considered potassium channel blockers. And then the calcium channel blockers are class 4. Class 1 drugs are the sodium channel blockers. And there are 3 categories of class 1 drugs, the A, the B, and the C. The class 1 drugs actually affect the action potential by lengthening or shortening it. And that's where we get the ABC classes. And you can see the drugs listed there in each class. Class 2 drugs are the beta blockers, and they reduce adrenergic activity of the heart. Sotalol is one of the most common ones used for antiarrhythmia purposes. Class 3 drugs are potassium channel blockers, and they act on the refractory period by acting on the potassium channel. Class 4 drugs are calcium channel blockers. They block the influx of calcium, so they reduce contractility by acting on the calcium channel. They have a negative inotropic effect, and they can reduce afterload. These are the adverse drug reactions that we can see. Hypotension is always up there. They can cause enough decreased contractility to exacerbate or cause heart failure, so we need to keep that in mind. Arrhythmias can be seen. We get some GI effects. We get atropine-like effects. And amiodarone in particular can cause hypo or hyperthyroidism, so we need to monitor the TSH. Pulmonary fibrosis, so if we see respiratory symptoms, we need to keep that in mind. They can develop corneal deposits, and there are a host of other ones listed there. Blue-gray skin tone, I think that's a really interesting one. As far as indications, atrial arrhythmias, we see all classes being used, especially class 1A. Amiodarone can be used in SVT and AFib, and verapamil can be used in reentrant tachycardia. Ventricular arrhythmias, such as ventricular ectopy, VTAC and VFib, we see class 1A, class 1B, and amiodarone. And keep in mind that some of these classes, as is shown here, can have a proarrhythmic effect in heart failure patients. So we need to use some caution with heart failure patients. Of course, many of them have this when we're considering use in these arrhythmias. So amiodarone, just to get a little bit more detail about, is a class 3. It has an onset of action that is from 2 days to 3 weeks and a duration of 7 to 50 days. So that's something to keep in mind when dosing and monitoring effects and adverse effects. Again, monitor the TSH, pulmonary function, and vision. Lots of drug interactions. So keep that in mind when you're prescribing something and anything in patients that are on amiodarone. Beta-adrenergic blockers, I'm not going to talk a whole lot about because they're discussed in chapter 14. But there are non-specific beta antagonists, selective beta antagonists, and those with and without intrinsic sympathomimetic activity, or ISA. So in post-MI patients, cardioselective agents that do not have ISA are preferred. Drugs with ISA may help avoid a decrease in cardiac output and heart rate. So they may be preferred in patients that get really bradycardic with other beta blockers. They're more effective in African American patients and in older patients. So, for example, in hypertension, we might use that first in a patient that is African American. Do need to keep in mind that, and we need to let patients know that they should not be abruptly withdrawn. You can actually get some anginal symptoms with abrupt withdrawal. Monitoring potassium, renal function. We need to let patients know that they need to be aware of interactions, especially with amiodarone. They should monitor their heart rate and rhythm, and they should monitor blood pressure at home as well. And that's the end of this one. We'll get into part 2.